Good afternoon, and thank you so much for participating and giving me your time this afternoon. I really appreciate it. I would like to talk about vasopressors in obstetrics, specifically vasopressor therapy for spinal anesthesia-induced hypotension during cesarean delivery. As a resident, fellow, and even more so today as an attending, I'm always curious as to why we do things, use certain medications, and how we came to do things that we do on a daily basis. So hopefully this lecture will give you a bit of insight into the progression we've made with vasopressors and where we might be going. I have no disclosures. And I'd like to talk today about spinal anesthesia-induced hypotension. It's frequent and has significant adverse effects on both mom and baby. I'll talk about some of the pathophysiology of hypotension, both historically and what we now understand as the etiology. I'll discuss the management with vasopressors, the history of the vasopressor use and our journey to our current state. And I'll give a brief hint at what I think are the important areas for future research. The most common surgical procedure performed in the world is cesarean delivery, and most are done under spinal anesthesia. Hypotension during spinal anesthesia for cesarean delivery should be minimized, both for maternal safety and comfort and well-being. If untreated, it's estimated that up to 80% of women will be hypotensive and that the vast majority will experience nausea and vomiting, which is very unpleasant for them. Interestingly, nausea is more frequent when ephedrine is used compared to phenylephrine, despite similar pressure control. This may be explained by a reflex response to decreased venous return, similar to the Beazell-Jaros reflex, which is more likely to occur with ephedrine. Hypotension can lead to decreased uterine blood flow and fetal adverse effects. As far back as the 1950s, supine hypotension syndrome, or aortocaval compression, was hypothesized to be the main culprit in spinal anesthesia-induced hypotension during cesarean delivery. Now, I know that the audience is extremely knowledgeable about this, but it's worth reviewing within its historical context. Traditional teaching is that aortocaval compression predisposes the parturient to decreased venous return and results in decreased cardiac output and blood pressure during spinal anesthesia for cesarean delivery. Now, this concept is that the gravid uterus compresses the great vessels, and when in a supine position, the compression of the IVC will decrease the blood return to the heart and drop cardiac output. And then to a lesser extent, the aorta is also compressed and can compromise blood flow to the uterus and placenta. The resultant reduction in central venous pressure and drop in cardiac output result in hypotension. Therefore, the mainstay of historical therapies included strategies such as fluid loading, leg wrapping, and left uterine displacement. However, these measures to improve venous return, including lateral tilt and numerous fluid administration regimens, have really failed to eliminate the hypotension and are only minimally effective. In fact, studies have shown that cardiac output actually increases immediately after spinal anesthesia. This was the first study in healthy pregnant women utilizing continuous invasive recording of arterial blood pressure, cardiac output, and systemic vascular resistance. The aim of this randomized trial was to compare the effects of two different intrathecal doses of bupivacaine with and without intravenous phenylephrine infusion on both cardiac output and systolic blood pressure. In this double-blinded study, 80 healthy women scheduled to undergo elective cesarean delivery were randomly assigned to one of 4 different groups, receiving 7 milligrams spinal bupivacaine with or without a simultaneous low-dose infusion of phenylephrine, or 10 milligrams spinal bupivacaine with or without the phenylephrine infusion. The primary outcome was the effect on cardiac output and systolic blood pressure. Immediately after spinal anesthesia, they found that cardiac output increased, heart rate increased, and stroke volume increased. And of course, as we would expect, systolic blood pressure decreased. You can see here that the authors found an initial prominent decrease in SVR resulting in the hypotension and an increase in cardiac output mainly due to increase in heart rate and stroke volume. The peak effect occurred at approximately 3 minutes after spinal initiation. The low-dose spinal bupivacaine group with the intravenous phenylephrine infusion was the most stable group regarding all hemodynamic variables. But what was interesting was that it showed the opposite of what so many had thought was the cause of the hypotension, that decreased venous return, decreased cardiac output, resulting in hypotension. In most cases, venous return is initially maintained, and consequently, there's a partial compensatory increase in cardiac output, and this is mediated by the increase in stroke volume and heart rate. What we now know as the mechanism, decreased systemic vascular resistance, was just being elucidated at the time, and was further supported by a study from Dyer and colleagues. They compared the effects of bolus ephedrine and ephedrine on maternal cardiac output and corroborated the previous study results that cardiac output actually increased after spinal anesthesia. At the pre-vasopressor time interval, cardiac output had increased due to an increase in heart rate and stroke volume. And I know that, it seems very logical and common sense today, but in the fluid replete parturient undergoing elective cesarean delivery, moderate spinal hypotension, about a 20% decrease from baseline, primarily reflects decreased systemic vascular resistance. Now, I have absolutely no doubt that aortocaval compression and decreased blood return to the heart exaggerate the hypotension, but the main mechanism is a decrease in SVR. The authors go on to further suggest that heart rate and not mean arterial pressure is the most important surrogate marker of cardiac output during spinal anesthesia for cesarean delivery. So in summary, it's really the loss of arteriolar tone that is the significant mechanism leading to hypotension after spinal anesthesia. And for this reason, it makes absolute sense that vasopressor therapy should be the mainstay of all the treatment. In this situation, the rapidly acting alpha agonist phenylephrine seems to be the most or the best option to restore baseline hemodynamics. But let's look at the evolution of vasopressor therapy for spinal-induced hypotension. In 1966, Labortino et al. Published a series of 234 cesarean deliveries performed under spinal anesthesia in New York. And yes, in the 1960s, they were using phenylephrine infusions. They used an intravenous infusion of phenylephrine, stating, "We selected phenylephrine as the vasopressor of choice, principally because it is a reliable drug that lends itself to intravenous drip administration. It is superior to ephedrine, as it does not have any effect on the central nervous system and does not lose its efficacy as a pressor agent on repeated administration." This still rings true today, but it took over 40 years to come back to the regular use of phenylephrine. So how did ephedrine become the vasopressor of choice for several years? Well, it was mainly due to concerns about placental perfusion with its use, solely based on animal studies in the 60s and 70s looking at the effect that phenylephrine had on the uterine vascular bed. This study showed that during actual and simulated spinal anesthesia and 21-term gravid use, induced maternal hypotension was associated with a proportionate decrease in uterine blood flow. Under these circumstances, phenylephrine and norepinephrine were administered intravenously, and they did succeed at restoring maternal blood pressure to normal, but failed to improve uterine blood flow, presumably because they caused uterine vessel constriction. Further work in pregnant ewes was done looking at additional vasopressor agents, including ephedrine. To evaluate the safety of prophylactic vasopressor administration, equipotent doses of 4 vasopressors, including ephedrine, were administered to 16 non-anesthetized pregnant ewes near term. Now let's review our adrenergic agents just for a second. Ephedrine and metaraminol are both mixed alpha and beta. Phenylephrine, mefentermine, and methoxamine are all alpha-1. In the study, when maternal blood pressure was increased by 50% with each vasopressor, uterine blood flow was unchanged with ephedrine, it was decreased by 20% with mefentermine, and was reduced 45% with metaraminol. It was reduced 60% with methoxamine. So metaraminol and methoxamine consistently decreased the uterine blood flow at all levels, and there was no significant change in fetal blood gas and acid-base variables in the study, which brings us to the problems with animal studies. if I could digress just a little bit, I want to go through the differences. So in pregnant ewes and pregnant women, there are different placental systems. Ewes have an epithelial-chorial system, while humans have a hemochorial placental system. What does this exactly mean? Well, in humans, fetal chorionic epithelium is bathed in the maternal blood because chorionic villi have already eroded through the maternal endothelium. In contrast, the chorionic epithelium of sheep fetuses remains separated from maternal blood, and it has at least 3 layers of tissue. And this results in an increased diffusion barrier. In addition, the human placenta is a low pressure system, whereas in sheep, the placenta is a high pressure system. And in the pregnant ewes, reduced sensitivity to angiotensin II occurs. And this occurs to a greater degree in the uterine than the systemic vessels, thus protecting the uterine blood flow. In addition, there's denervation of the uterine arteries and an overall reduction in both systemic and uterine responses to the effects of circulating catecholamines. This happens in humans too, but to a lesser extent. This denervation leads to an increase in postsynaptic alpha-adrenergic receptor sensitivity. This makes the uterine arteries of the pregnant ewe relatively more sensitive than the systemic arteries. In humans, uterine arteries are not as sensitive, and even high doses of alpha agonists have had little effect on placental blood flow. And this is due to the differing placental anatomy and physiology. Thus, uterine blood flow is sacrificed in the sheep to ensure survival of the mother when needed. The early studies of vasopressors in obstetrics focused mainly on differences among agents in their effect on uteroplacental blood flow. And the animal studies showed that uterine placental blood flow was better maintained with ephedrine compared with alpha agonists. And this led to the eventual clinical recommendation that ephedrine should be the vasopressor of choice in obstetric anesthesia, because greater uteroplacental blood flow should correspond to greater oxygen supply to the fetus. However, it's now well established that in the gravid ewe, the response of the uterine vascular bed to vasopressor agents is vasoconstriction, which is proportionately greater than the increase in mean blood pressure, with the net effect of a decrease in uterine blood flow. But in humans, even if phenylephrine decreases uterine blood flow, there is little effect on overall well-being of the fetus, probably because of the significant placental reserve. Thus, the focus began to switch in the late 1990s and early 2000s to evaluate alpha agonists again. The researcher really leading the way in this movement is Dr. Warren Nahnke. In 2005, Nahnke and colleagues described the first really effective technique for preventing hypotension during spinal anesthesia for cesarean delivery. Non-laboring patients scheduled to undergo elective cesarean delivery received an intravenous infusion of 100 micrograms per minute of phenylephrine that was started immediately after spinal injection and was titrated to maintain systolic blood pressure near baseline values until uterine incision. In addition, the patients received an infusion of lactated ringers. It was given either rapidly or at a minimal maintenance rate. Maternal hemodynamic changes and the neonatal condition were compared. And the results show that only 1 in 53 patients, or 1.9% in group 1, that's the rapid LR bolus, experienced hypertension versus 28.3% in group 0. Compared with group 0, patients in group 1 had greater values for serial measurements of systolic blood pressure, minimum recorded systolic blood pressure, and minimum recorded heart rate. Furthermore, total phenylephrine consumption was smaller in group 1 compared with group 0. The neonatal outcome and maternal side effects were similar between groups. And the authors concluded that a combination of a high-dose phenylephrine infusion and rapid crystalloid cohydration is the first technique that had been described that is effective at preventing hypotension during spinal anesthesia for cesarean delivery. However, despite this convincing data, phenylephrine's acceptance as the vasopressor of choice was still very slow. But several studies started coming out demonstrating that ephedrine was associated with depression of fetal acid-base status. So Dr. Nan-Key looked at the fetal effects of phenylephrine and ephedrine and hypothesized that the mechanism underlying the depression of the fetal acid-base status was actually transfer of ephedrine across the placenta and stimulation of metabolism in the fetus. Well, why? If you look at the chemical structures of ephedrine and phenylephrine, both ephedrine and phenylephrine are structurally related. However, unlike phenylephrine, ephedrine lacks hydroxyl substitution of the aromatic ring, and in addition, it has an alpha-methyl substitution of the ethyl side chain, which phenylephrine lacks. So ephedrine can be expected to have greater lipid solubility than phenylephrine, which explains its greater placental transfer. In this study, a total of 104 women having elective cesarean delivery under spinal anesthesia randomly received an infusion of phenylephrine or ephedrine, titrated to maintain systolic blood pressure near baseline. At delivery, maternal arterial, umbilical, and umbilical venous blood samples were taken for measurement of blood gases and plasma concentrations of phenylephrine, ephedrine, lactate, glucose, epinephrine, and norepinephrine. In the ephedrine group, umbilical arterial, and umbilical venous pH and base excess were lower, whereas umbilical arterial and umbilical venous plasma concentrations of lactate, glucose, epinephrine, and norepinephrine were greater. The study showed that ephedrine crossed the placenta to a greater extent than phenylephrine, as evidenced by considerably greater values for the umbilical venous to maternal arterial plasma concentration ratios in the ephedrine group. Ephedrine was associated with greater umbilical arterial and umbilical venous plasma concentrations of lactate, glucose, epinephrine, and norepinephrine. Furthermore, the plasma concentration ratios were also greater in the ephedrine group, which suggests that ephedrine undergoes early metabolism or a redistribution in the fetus, and that was to a lesser extent than phenylephrine. The results confirmed the previous results from other studies that have shown that ephedrine is associated with lower fetal pH and base excess compared with phenylephrine. Together, these findings are consistent with the hypothesis that the mechanism underlying the propensity for ephedrine to cause fetal acidosis is transfer of the drug across the placenta and stimulation of metabolic processes in the fetus. So despite historical evidence suggesting uteroplacental blood flow may be better maintained with ephedrine, the overall effect of the vasopressor on the fetal oxygen supply and demand balance favors phenylephrine. Nan-Key continued to study phenylephrine in an attempt to further optimize the treatment of spinal-induced hypotension. In this study, there were 125 women undergoing elective cesarean delivery under spinal anesthesia, and they were randomized to receive either an IV infusion of phenylephrine and ephedrine. It was actually combined. So they were randomized to receive an IV infusion of phenylephrine and ephedrine combined in one of 5 different concentration ratios. And here are the detail of those concentration ratios. The authors did make an assumption in this study that phenylephrine 100 micrograms is approximately equipotent to ephedrine 8 milligrams. The infusions were adjusted to maintain blood pressure near baseline until uterine incision, and hemodynamic changes in umbilical cord blood gases were compared. And what they found is that as the proportion of phenylephrine decreased and the proportion of ephedrine increased, the incidence of hypotension increased, nausea and vomiting increased, maternal heart rate increased as would be expected, fetal pH and base excess decreased, umbilical arterial oxygen content decreased, and umbilical venous PO2 increased. So when varying combinations of phenylephrine and ephedrine were given by infusion to maintain arterial blood pressure during spinal anesthesia for cesarean delivery, as the proportion of ephedrine increased, hemodynamic control was reduced and fetal acid-base status was less favorable. They concluded that combinations of phenylephrine and ephedrine appeared to have no advantage compared with phenylephrine alone. But that still doesn't tell us what the optimal dosing range is for phenylephrine. Stewart and colleagues attempted to answer that question, especially since there are concerns about phenylephrine's propensity for causing increase in afterload and a baroreceptor-mediated bradycardia in the mom. This would potentially lead to a reduction in maternal cardiac output. So this study examined the use of a non-invasive measure of cardiac output to investigate whether there were any dose-dependent effects of phenylephrine on maternal cardiovascular stability, and if so, what was the impact on fetal outcome? In this randomized double-blind study, 75 women scheduled for elective cesarean delivery under spinal anesthesia were allocated to receive a phenylephrine infusion of either 25, 50, or 100 micrograms per minute. And the infusion was titrated to maintain maternal baseline systolic blood pressure from induction of spinal anesthesia until delivery. They used a suprasternal Doppler monitor, and they measured cardiac output, stroke volume, as well as measures of venous return and contractility. They also looked at APGAR scores and umbilical cord blood gases. What they found was that blood pressure was controlled in all groups. There was a significant time and dose-dependent reduction in heart rate and cardiac output with phenylephrine as expected. And there were no significant differences in the number of times blood pressure decreased below 80% of baseline, or the number of boluses of ephedrine or phenylephrine required as rescue. Stroke volume remained stable throughout, and APGAR scores and umbilical cord blood gases were similar among the groups. They concluded that by infusing a higher concentration of phenylephrine, you subject the mother and fetus to a much higher dose of phenylephrine, with significant effects on maternal heart rate and cardiac output. This is important because there is evidence to suggest that cardiac output, specifically the maximum change in cardiac output, actually correlates more closely with uteroplacental blood flow than blood pressure. Allen and colleagues also looked at determining the optimal dose of phenylephrine. 100 women undergoing elective cesarean delivery under spinal anesthesia were randomized to placebo or prophylactic phenylephrine infusion at various rates. They all received a 2-liter fluid co-load, and maternal blood pressure was maintained within a target range. The authors compared the number of rescue boluses, hemodynamic parameters, incidence of nausea and vomiting, and umbilical cord gases between groups. The authors found greater hemodynamic stability with the lower doses of phenylephrine, namely the 25 and 50 microgram per minute infusions, compared with the higher doses of 75 and 100 micrograms per minute. Of these regimens, phenylephrine at a dose of 50 mics per minute was associated with a significant reduction in the incidence of pre-delivery hypotension, and the number of hypotensive episodes compared with the control group. In addition, whereas the 25 mic per minute infusion regimen had a lower incidence of pre-delivery hypertension when compared with the higher 100 mic per minute group, both the lower infusion rates of 25 and 50 mics per minute were associated with fewer episodes of reactive hypertension. However, there really was no difference in the number of interventions needed to maintain blood pressure within the target range. And the authors concluded that prophylactic phenylephrine infusions reduce the incidence and severity of maternal pre-delivery hypotension. Among the fixed-rate infusions, 25 and 50 micrograms per minute were associated with greater hemodynamic stability compared with the higher rates. So therefore, if a prophylactic fixed-rate infusion is used in conjunction with a fluid co-load, the lower rates are most appropriate. So that brings us up to speed on the progression to the current state. Just to recap, for healthy women undergoing elective cesarean delivery under spinal anesthesia, recommendations for best clinical practice to avoid and/or minimize maternal and fetal adverse effects associated with spinal-induced hypertension are that there should be IV colloid preload or crystalloid co-loading, and left uterine displacement should continue to be used. Vasopressors should be used prophylactically. The alpha agonists are the most appropriate agents to treat or prevent spinal-induced hypotension, and phenylephrine is currently recommended due to the amount of supporting data for its use. Now, the goal should be to maintain systolic arterial pressure as close to baseline as possible, but at least at 90% of the pre-spinal baseline pressure. Avoid large drops in pressure, and the phenylephrine should be given as a prophylactic infusion using a syringe pump and should start at a lower dose, around 25 to 50 mics per minute, and then titrated to both blood pressure and heart rate. Rescue boluses of either phenylephrine or ephedrine are both appropriate and both may be needed to maintain the BP. And maternal heart rate is a good surrogate for cardiac output. Tachycardia, bradycardia should be avoided. And for bradycardia with hypotension, a vagolytic may be needed, but its use should be used with caution because as increasing heart rate and cardiac output could result in rebound hypertension. When we look to the future areas of study, I think that there are three that really stand out. We have already started looking at vasopressor use in the compromised fetus. We now know that phenylephrine given during spinal anesthesia for low-risk cesarean delivery is associated with higher fetal pH than ephedrine. However, there is less robust evidence on the effects of ephedrine and phenylephrine in complicated pregnancies. Are there other vasopressors we should be investigating and using? Also, titrating infusions is not that labor intensive for the anesthesiologist, but can technical advances in our pumps lead to better management? I'll discuss briefly a closed loop delivery system. And what role does genetics play in the response to vasopressors? Well, first, let's look at some of the data on vasopressor use in high-risk pregnancies and the compromised fetus. Cooper and colleagues retrospectively examined outcomes in women who underwent non-elective cesarean delivery under spinal anesthesia for fetal indications. And those fetal indications were non-reassuring fetal heart rate tracing, dystocia, preeclampsia, growth restriction, hemorrhage, prolonged rupture of membranes, or cord prolapse. The phenylephrine infusions were standardized in this retrospective study, but ephedrine infusions were not very common, and they were not standardized. And the authors found no difference in umbilical artery pH between ephedrine and phenylephrine. Nanki also looked at this issue and randomized women undergoing non-elective cesarean delivery with spinal anesthesia to receive either ephedrine or phenylephrine boluses for the treatment of spinal anesthesia-induced hypotension. There were no differences in umbilical artery pH or other neonatal outcomes. However, one of the limitations of the study is that women with hypertension were specifically excluded. MOTA randomized women undergoing emergency cesarean delivery for fetal compromise with spinal anesthesia to receive either ephedrine or phenylephrine boluses, and also found no difference in umbilical artery pH, incidence of fetal acidosis, or APGAR scores. Again, however, women with preeclampsia were excluded from this study. Etuk and al. Retrospectively studied women with preeclampsia who had spinal anesthesia for cesarean delivery, and these women received bolus doses of phenylephrine or ephedrine to treat hypotension. Again, the investigators found no differences in umbilical artery pH. But these studies are not standardized. Most are not prospective. Prospective robust studies in compromised pregnancies are lacking. And so we set out to look at that, myself and a group. A group from Northwestern collaborated with our South African colleagues on 2 studies in preeclamptic women undergoing cesarean delivery under spinal anesthesia. And we set out to prospectively investigate vasopressor use in women with severe preeclampsia. In the first study, patients with preeclampsia requiring cesarean delivery for a non-reassuring fetal heart rate tracing were randomized to receive either bolus ephedrine, 7.5 to 15 milligrams, or phenylephrine, 50 to 100 micrograms, to treat spinal hypotension. The primary outcome was umbilical artery base excess, and the secondary outcomes were umbilical arterial and umbilical venous pH and lactate concentration, venous base excess, and APGAR scores. Among the 64 women who required vasopressor treatment, pre-delivery blood pressure changes were similar. There was no difference in mean umbilical artery base excess, mean umbilical arterial and venous pH, no difference in lactate concentration between groups, and there was no difference in the 1 or 5 minute APGAR scores. We concluded that in patients with severe preeclampsia and fetal compromise, the fetal acid-base status was independent of the use of bolus ephedrine versus phenylephrine to treat spinal hypotension. In the second study, we hypothesized that phenylephrine, as compared to ephedrine, would result in higher umbilical artery pH in women with preeclampsia undergoing cesarean delivery with spinal anesthesia, similar to the studies we had seen historically in healthy women. This study was a randomized, double-blind clinical trial. Non-laboring women with preeclampsia scheduled for cesarean delivery with spinal anesthesia were randomized to receive either a prophylactic infusion of ephedrine or phenylephrine titrated to maintain systolic blood pressure greater than 80% of baseline. We modeled our algorithm for the treatment of blood pressure on the initial protocols described by Nanki in his landmark work in healthy women. Our primary outcome was umbilical arterial pH, and the secondary was umbilical artery base excess. 110 women were enrolled in the study. Mean umbilical arterial pH was not different between groups. There was also no difference in the umbilical artery pH stratified by magnesium therapy or by the severity of preeclampsia. We were unable to demonstrate a beneficial effect of phenylephrine on the umbilical artery pH compared with ephedrine. Our findings suggest that phenylephrine may not have a clinically important advantage compared with ephedrine with regard to improved neonatal acid-base status when we're using it to prevent spinal anesthesia-induced hypotension in women with preeclampsia. Unfortunately, the jury is still out, and future studies are needed to further explore vasopressor regimens in preeclamptic women. And Dr. Nanki recently did a meta-analysis on prophylactic phenylephrine and ephedrine infusions and bolus treatment in women with compromised pregnancy, and still there's no significant consensus on optimal therapy. What does the future hold for the vasopressor drugs that we use? Could other vasopressors be superior to phenylephrine? You know, phenylephrine does cause baroreceptor-mediated bradycardia and a consistent decrease in cardiac output. Maybe those alpha agonist drugs with a small amount of beta agonist activity like norepinephrine may actually have a better profile to maintain systemic vascular resistance and maintain cardiac output. Since norepinephrine has both beta and alpha adrenergic activity, it's suitable for maintaining blood pressure with less bradycardia. The authors in this study hypothesized that norepinephrine would be superior to phenylephrine, requiring fewer rescue bolus interventions to maintain blood pressure. 85 parturients having spinal anesthesia for elective cesarean delivery were randomized to group P, which was a low-dose phenylephrine infusion, or group N, which was a norepinephrine infusion of 0.05 mics per kilo per minute. Rescue bolus interventions of phenylephrine 100 micrograms for hypotension or ephedrine 5 milligrams for bradycardia with hypertension were given as required to maintain systolic blood pressure. Maternal hemodynamics were measured non-invasively. There was no difference between groups in the proportion of patients who required rescue vasopressor boluses. The incidence of emesis was greater in the phenylephrine group than the norepinephrine group, and this was statistically significant. Hemodynamic parameters including heart rate, the incidence of bradycardia, blood pressure, cardiac output, cardiac index, stroke volume, and systemic vascular resistance, and neonatal outcomes were all similar between groups. So the authors concluded that a norepinephrine fixed-rate infusion has efficacy for preventing hypotension and should be considered as an alternative to phenylephrine. Nanki also studied norepinephrine. And in this double-blind, randomized controlled trial, 110 healthy women having spinal anesthesia for elective cesarean delivery were randomly allocated to one of two groups. In group 1, the patients received an infusion of norepinephrine starting at 2.5 micrograms per minute, immediately after intrathecal injection, and then manually according to value, and then it was titrated manually according to values of systolic blood pressure. They measured the blood pressure non-invasively at 1-minute intervals until delivery, with the objective of maintaining values near baseline. In group 2, there was no prophylactic vasopressor given, and a bolus of 5 mics of norepinephrine was given whenever systolic blood pressure decreased to a preset value. Comparisons between groups showed that systolic blood pressure was greater over time in the norepi infusion group versus the bolus group. And the authors concluded that this study showed that a manually titrated infusion of norepinephrine was effective for decreasing the incidence of hypotension during spinal anesthesia during elective cesarean delivery. It was associated with a low incidence of bradycardia and no evidence of any adverse effect on neonatal outcome. And they suggest further investigation of the use of dilute norepinephrine infusions for routine use in obstetric patients. So it is possible that we will begin seeing more norepi use. The same group has been experimenting with closed-loop controlled delivery systems for vasopressors. This is a schematic diagram of a closed-loop controller for the infusion of phenylephrine during cesarean section under spinal anesthesia. The target systolic blood pressure is entered as the set point, and user-defined upper and lower values for systolic pressure and heart rate are entered for alarm limits. Monitoring data, the input signal, is received from the anesthesia machine and analyzed at 2-second intervals. A simple on-off control algorithm activates the syringe pump, which is the control signal, and to deliver phenylephrine at 100 mics per minute, for example. And that happens when the measured value for systolic pressure is less than or equal to the set point. The infusion will stop when the systolic pressure exceeds the set point. And what they found was, by using this computer-controlled closed-loop delivery system, BP control was more precise. However, the differences are small, and we don't really know if this is associated with any clinical relevance. It's just interesting and potential for technology improvements. Finally, because of the wide variability in the incidence and severity of hypotension after spinal anesthesia, there has been a growing interest in the possible impact of genetic predisposition. Landau et al. Had previously demonstrated that the beta-2 adrenoceptor, called the ADRB2 genotype, can affect the amount of ephedrine administered to maintain blood pressure during cesarean delivery with spinal anesthesia. This study investigated whether that ADRB2 genotype affected phenylephrine dose requirements during cesarean delivery. The hypothesis was that the ADRB2 genotype altered the phenylephrine dose response, and that they would not see this effect if phenylephrine was the vasopressor used to maintain the blood pressure, because phenylephrine does not act via the B2 or the beta-2 adrenoceptor. They included 96 women and found that there was a statistically significant difference of 200 micrograms between two ADRB2 genotypes, although it is really unknown if this difference is clinically relevant. The genetic component of the ADRB2 genotype may contribute to a more severe hypotensive response after spinal anesthesia and have varying responses to sympathomimetics. So in summary, the optimal vasopressor dose and delivery for spinal anesthesia-induced hypotension is yet to be determined, and I think it will change in the future. The current data that we have supports phenylephrine as the vasopressor of choice because of the breadth of research and the safety profile that's been determined. I really believe that future research should continue to focus on the compromised fetus, and I think we will see more studies looking at the potential genetic predisposition of individuals and their responses to different medications in the future. So I thank you very much for your attention. I welcome any questions, and I have a list of references in my presentation if anyone is so interested. So thank you very much.